I want to take you through the practical stuff regarding phantom limb pain and the treatment thereof in the different processes that I'm going to show you. I'm not going to go into all of the technical theory and the neurobiology and all the in-depth stuff for two very simple reasons. One is I don't really know it, but the other one is that I've recently started working with a university project and working with some of the researchers there who are all PhD graduates, top of their class in everything they've ever done. I've realized just how much I don't know about the academic side of stuff. What I do know a lot about is the practical and application. Now, let me tell you how all this came about. Just over 10 years ago, I worked with somebody who had phantom limb pain following amputation, had seen lots and lots of clinicians, lots of therapists, had hypnotherapy and all sorts of other things, and nothing had improved. They had previously used the mirror box, which I'll show you later, is just a mirror. And nothing had worked. I used the mirror box with them, and it was pretty much the first one I'd ever done, didn't know really much about it, and it worked. So I thought, okay, this is interesting. There's something happening between when it's effective and when it's not effective. I set up two websites, phantomlimb.org and another one which I forget now, and I started collating data from clinicians all around the world to find out, what do you know? If you're using the mirror box, when does it work? When doesn't it work? And I started collecting that data. So I had lots and lots of feedback. One of the interesting things was the feedback that came out of various African states with aid agencies who were using the mirror box there, particularly in Rwanda, where people were having limbs hacked off if they'd had immunizations. It was a way of basically incapacitating UNICEF and the United Nations by terrorizing the civilian population by chopping off the arms that the immunizations had been given them. That was the rationale they were using for the brutality. So there was a lot of amputees. It seemed reasonable to use the mirror box because it's very cheap, it's very effective most of the time, and it's easy to use. But they were having particular problems that were occurring, primarily because the effect is such a weird experience. They were having people completely freaking out and running out of the treatment rooms, out into the fields or the jungles or wherever it was in the towns they were living, and not going back again. Because their experience of what was happening fits into a cultural paradigm, which is very different from the Western biomedical models that we have. There, they have different spiritual practices and beliefs. So I started collating it and then applying some of those differences to the clients that I was working with. The observation that I found was that the majority of people that I was working with, I can only think at this moment in time of one exception that hasn't worked, and this was a videoed session. Even though that they had mirror box treatment previously, by knowing these differences, I was able to get it to be effective for people. And that's primarily what this work is going to be. So that's what I'm going to show you. My early experiences of phantom limb was as a student nurse on a general surgical unit. We had two surgeons. We had a guy called Steve Slaughter, which was a very brilliant name for a surgeon, and we had another guy who, because he's still in practice, I can't tell you, but those two guys were famous for their amputation work. They would effectively be the guys that if you needed an amputation in that health authority, these would be the fellas that would do it, and very good jobs they did. There would be two things that I saw happen. One is we'd have patients, it was mostly lower limb, so it was mostly legs. They would come in with excruciating pain from whatever the condition. Most of them were medical conditions, so it was poor circulation. This wasn't through trauma. So they were scheduled amputations when the limb hasn't been saved. Now, because when circulation is affected, things can become very sensitive. I don't know if you've ever had a leg that's gone to sleep, and then you touch that leg. It's quite an extraordinary experience. So patients would have to have what we call a bed cradle. So they'd be lying in bed, and there would be a thing that would lift all the bedding off the limb to stop the pressure on them causing pain. Following amputation, those same patients would frequently still require a bed cradle to keep the sheets off the limb that is no longer there. Because it was like the visual input of seeing the sheets over where the leg was, because they'd been very accustomed to the pain, would cause them excruciating pain. And that seemed to be quite an unusual event, although unusual in its effect, but quite common amongst certain groups of patients. Interestingly, the staff never commented on it, never thought it to be anything of noteworthy, and it was just largely dismissed. They were given the bed cradles to lift up the sheets, but that was the extent of what would happen for those people. They would be given painkillers, which were usually not that effective. The other thing that I saw was the more the kinesthetic representation of a limb, and this was mostly the men who either, days after the amputation would wake up in the morning and get out of bed to have a pee, and they've forgotten the limb's not there. Because somatically, kinesthetically, it feels like it's there. And they would swing the legs over, or leg, go to stand up, and then promptly fall over, forgetting it was there. Now, it was often that also was dismissed. It's like, well, it happens, that's just, it's just what it is. But I never saw any further investigations of what that was about. So, my point with this is that there's two types of representation. We have visual feedback, and we have the kinesthetic or the somatic representation of the thing that's not there. And an understanding of the differences of those two things is really important in making a difference. The mirror box itself, it's not very glamorous. It's a mirror and a box. Now, I deliberately have this, which is a basically crappy old cardboard box and a mirror that doesn't quite fit. Okay, this I did have, as some of you may have seen on the website, I did have the proper made. They look surgical. They look like medical equipment and kit. Actually, my father made those, and they were made with absolute precision. The mirror, whatever, was at the right angles to create a perfect illusion. That was brilliant, but here was the problem. Patients that I was working with thought that's what they needed to have in order to work with the mirror box. So, because I don't work clinically, I'm not working in a hospital or a medical center. I work in the spare bedroom. We call it the office, but let's be realistic, it's the spare bedroom in our little flat. This suffices because I'm working with people in a different context. If I was working in a medical clinic or in a hospital clinic, I wouldn't have this. I might have one of these to show people, but it's not what I'd be working with because it's the wrong, it doesn't fit into the context. And it literally is just a mirror stuck on a box. You can have a hole in it or not. And I'll show you what that is, what we do with this. This was developed from, or the concept of the mirror box was Vilyanur, I don't know if I said that right, Ramachandran, who's a neurologist. He wrote a book called Phantoms in the Brain, where he was looking at some of the weird effects that happen around phantom limbs. The old treatment for phantom limb pain was to chop another inch off. So they would go, well, the phantom limb there, obviously there isn't a limb, therefore it can't be. So if we take another piece off, that should work. Now, for some people it did, and there's the problem. Because for those people that it did work for, it was really effective. So in that classic thing of a very effective treatment working for some people but not all, it becomes the state or the go-to treatment process. And now people realize that's not the case. They were having another problem that was causing the pain. Just trying to think if there's any other little background things to give you. One other example of phantom limb that I saw when I was nursing. And she was basically put in a position where here's your commode, curtains around, get on with it. She's not very happy with that. She gets out of bed, she goes to sit on the commode, they haven't put the brakes on. And what happened was the commode slipped away from underneath her and she went down awkwardly, causing a compound fracture of the femur. So she fell very, very heavily. Now, that's a horrific injury that is incredible in the context of just falling from a standing position by the bed. That's normally sort of a traffic accident type injury. Well, there's the problem, and a number of things happened that basically meant errors were made and infection got set into the bone, and she lost the leg right up at the hip. I think her mental state would be fair to be described as pissed off. No, she was absolutely, she had nothing but contempt for people. And her level of pain in the phantom limb was extraordinary. I mean, she was really, really, really suffering. Now, the problem was she's on a neurological unit. And what amazed me was there were no members of staff that I worked with that were aware of phantom limb pain and its treatment. And that really shocked me. That was quite a surprise to me. So, in talking to some of the doctors, people say, well, is there anything you can do? That we'd be grateful, you do whatever you do within the remit of professionalism. So one of the things I asked her was, when you think about the limb that's not there, the phantom, what does it look like? What is that? And what she describes is a very injured, twisted, damaged leg. It's almost like her brain has taken an imprint of the moment of the injury, and that's what it's now stored for whatever reason. That's what's locked in, and that's what she can see. Now, what I did was a technique from NLP, neuro-linguistic programming, which was to simply compare it to the other limb. How big is the picture? How bright is the picture? Is it in color or black and white? Is it moving or still? All of what we would call submodalities. And essentially, I changed the picture of the limb to that of the healthy one. And that created a significant improvement in her pain. Now, that process probably took, 20 to 40 minutes. In the middle of that, the orthopedic team arrive and talk to her. I mean, I'm just pushed aside. Who am I? I'm just a nurse. And so I'm put aside. They go and do their stuff, and then they leave, and then I carry on pretty much where I left off. And that was quite significant in terms of her pain reduction. She was subsequently transferred, so I have no long-term follow-up on that. But it kind of got me interested that if we start changing the representation of the phantom, we can start changing the experience of the phantom. This is what Ramachandran knew, except he had a much better, much more effective, much more realistic way of doing this, which was to use a mirror. Point a mirror at it, create a reflection from the other one, let's see what happens. So that's a little bit of the background. I want to take you through some of the things that I'm aware of in working with phantom limb. Predominantly it's the assessment of it. This is where people fail time and time again in the correct assessment of a patient who has suffered horribly. The first consideration I always have is for things like post-traumatic stress disorder. Not all amputation happens as a result of trauma, and not all phantom limb is connected with post-traumatic stress disorder. These are just some of the considerations. Things like poor circulation, circulatory disease, diabetes, things like this can result in an amputation. Infection, meningitis, those kind of infections. Anything that involves systemic infection can affect circulation to the peripheries, which is why you often see on the news or in those TV shows the unfortunate meningitis patient who's lost all their limbs, and sometimes they don't even have ears because the circulation was so impaired by the infection. Now, with that, if we look at post-traumatic stress where there is not a violent or aggressive incident, or there's not a damage to the body in something that happens, it's a gradual process. Post-traumatic stress may still occur. For example, there's a lot of stuff around the stress of being that patient, both before being ill, being in the illness process, and then waking up. Especially if you've been intubated in an intensive care department and you wake up and all of your senses tell you everything's fine because you haven't had any opportunity to update what's happened to the body. And then as you come round, blah, 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 how am I doing? Oh, you're doing fine, you're in the right place, you're in hospital, everything will be fine. You haven't got any legs and arms, but everything will be fine. There's lots of things that can happen around that and the stress of discovering the situation with the body, they can actually create a significant PTSD. Not everyone will, and that's important. My observation of therapists generally is they love to diagnose trauma. It's their favorite thing in the whole wide world. Bulimic, you must have had trauma as a child. Too big, you must have had trauma as a child. Anxiety, you had trauma as a child. It's all about trauma, 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 and they love it. When there's a physical injury, oh, you must have been traumatized. A gentleman, actually in this very room, I did some filming with, he was involved in a horrendous motorcycle accident. He suffered what's called a brachial plexus injury, and it took off his arm. Well, they took off his arm as a result of the injury. He walked in, very tall, very confident, and he was wearing a Harley-Davidson t-shirt. That suggests there's a clue there that this is a guy who may not be suffering post-traumatic stress from the accident. And I asked him about that, and he said, clearly not. He was absolutely fine. For some people, if it's an accident, it's the most exciting thing they've ever experienced. It's not necessarily the most awful thing they've ever experienced. Some people will have a mixed view. It's both an exciting thing and it's a horror. It could be a whole mix of different things that can occur to people. And to label it as being one single emotional entity, I think is a grave error. If you want to drive someone crazy, do this. Assume them to be traumatized by something they're not. And whenever they try and tell you they're fine, continue to assume they're not. And replicate that with everyone that knows that individual. Most of us have experienced something like that to a different degree in some point in our lives. It makes me want to start slapping people, and then they go, see, he's traumatized. Look how angry he gets. And this is one of those unfortunate things of the nature of people. Now, other things that can happen with amputees, especially if there's been a serious incident, there may be lots of things that happen afterwards. So not only have they lost a limb, but there may be people in jail. It may be people they knew, because it may be they're not entirely the victim. The incident was there were other people who were responsible, and they may be doing jail time, or they may be accused of stuff, or whatever. There may not be people in jail, which for some people can be a problem. This is what he did to me. He wasn't paying attention when he pulled out on the junction. As a result, I've lost my arm, I've lost my leg, and all he got was a £500 fine and a 3-month ban. For some people, there's a very, very strong sense of injustice. That's not post-traumatic stress disorder. It might keep the person awake, it might drive them crazy, it might drive them to drink. That's not post-traumatic stress disorder. But therapists who are naive to these things start to assume it is, and then they start grouping it all as one entity, and then diagnose the person accordingly. Other things with post-traumatic stress, my observation in working with PTSD clients, of which I work with a lot, it's very rarely the event that happens to the client that's the problem. That's not what keeps them awake at night. It's what they were doing that keeps them awake at night and forms the regret. For example, one amputee I worked with, at age 18, he was leaning back on a chair. Do you know what he was doing? He was just leaning back on the chair, and he just so happened to topple over backwards, and behind him was a glass window. And as he went through the window, it severed the arm, well, severed enough of the material of the arm that an amputation was subsequently necessary to save him, really. So for a simple little thing like that, the consequences on the man's life is absolutely huge. I mean, the accident nearly killed him. You can imagine being in a student environment where you've got a level of injury to the severity that he had, and you're surrounded by basically a teacher and lots of other students. You're not necessarily going to get the best immediate first aid. What would keep him awake at night? It didn't, but the kind of thing was, if only I hadn't been leaning back on the chair. It won't be the blood and the screaming and all the rest of it. It will be what he was doing during that thing to bring it about. If only I hadn't left home to go to work at the time I did, I should have left at my normal time. I wouldn't have hit that car. it's these trivial little details that tend to bother people the most, and keep people in this loop of trying to go back in time to the original event to change it. And so essentially, to change where they are now, they want to go back to change what happened. Now, the problem with that is the person can never be future orientated because they're always retrospectively orientated. So they're stuck in the past. Now, in order to get a person to adapt to an amputation, in order to get them to change their organization of self, especially neurologically, we need to get them to be more future focused. So a retrospective loop will trap people. The other thing that will happen is PTSD heightens awareness. People become hypervigilant. The result of that is they become hypervigilant to all stimuli. It's not very selective, particularly anything that would provoke a startle response and pain. We know that people with chronic pain don't desensitize to the pain over time. Their sensitivity to pain increases. Most individuals think people with chronic pain should and ought to, for the benefit of everybody else, desensitize or at least shut up and stop talking about it. Stop moaning, go, ooh, ah, that really hurts. Because most people's tolerance lasts 3 days. That's the general statistic. So the longer the person has the pain, the more sensitive to the pain they become. If they got PTSD symptoms, they'll become hypervigilant to that pain as well. They become retrospectively focused. Therefore, they're not going to be very future orientated in changing their organization. Because of that, it is essential that PTSD and time orientation is addressed in patients, if it's present, prior to using the mirror box. Because what will happen is the person will use the mirror box and they will start to see things in their future only in the terms of the past. They're not going to reorganize themselves too readily to change their experience, because the solution for them comes in changing retrospective events that are over and have happened rather than changing what's going to happen in the future. So it's very, very hard for PTSD patients to get them to use a mirror box effectively. And this was one of the key differences that I found. And there's lots of ways of working with PTSD, which is really outside of what we're doing here in the workshop. I've made some notes up here just to remind myself, so please just bear with me a second.
Andy, would I be right in saying that post-traumatic stress would be what they didn't do?
It can be. It can well be. Again, it's if they can now do that behaviour of the thing they didn't do, the problem would never happen. Yeah. And it's just hopeless. It can't be done. It's an impossible situation, but it seems to be a very, very natural thing for people to try and do. Now, there's two other interesting observations which most clinicians working in major surgery will have witnessed a lot. And this is a physical injury to the body is interpreted biologically the same way, whether it's done through violence or whether it's done through surgery. And there isn't a great deal of difference at the biological level of what's happening. So, for example, we often, when I worked in accident and emergency, we would see patients with a head injury, and they've been really whacked on the head, and they become violent. And I don't know if you've ever banged your head accidentally, not in an act of violence, but it can feel like a violence has been enacted on the body. And some people then respond to that by coming out fighting. The weird thing can happen is that major trauma to the body, including surgery, whether it's by accident or whether it's by an operation, can afflict a major stress on the body, the result of which is the body changes its hormone levels, all sorts of chemical changes occur. About 6 weeks later, you'll see the person have a crashing depression, and they don't understand why they're so miserable. And you'll see this with cardiac patients, heart transplant patients, people who had heart bypass. I've seen it with spinal surgery patients, hip replacements, people who fractured a femur and had it successfully treated. The cast comes off, they feel great, it's a relief, and then 2 days later they find themselves crying and they don't know why. They can't understand it. And it's because of the stress response the body has given. Now, not all phantom limb occurs straight after amputation. It can occur long time later, anywhere from days to months to, I have heard of cases of years, probably not that common. And it seems to me that one of the things that can happen is when people become depressed, awareness of pain sensitivity increases. Depression literally hurts. And we know that emotional pain is processed by the same part of the brain that does physical pain. So it really does hurt, say, when you lose a whole load of money. It really hurts when somebody breaks your heart because it's interpreted the same way. And it seems that major injury on the body can then subsequently cause a biological organic depression, which seems to be it can trigger awareness of pain that wasn't there previously. A lot of people who are hypochondriacs, they have a situation where everything aches and they're constantly finding a symptom here and there. There's something wrong with this finger, there's something wrong here. Have they got fibers in the skin? What is that itch? Why won't that go away? And actually it's depression. It's just that their pain threshold has been adjusted for them by the depressed brain functioning. So they become very, very aware of stuff. So these are things that are important to be aware of. Now, other things I'll look at, what I call dysmorphic distress. If you lose an arm or lose a leg, your identity changes profoundly. The way people look at you when you walk in a room, the way people greet you, do they hand you a pen, do they shake your hand? Oh God, if I hand you a cup of tea, what do I do? Do I hold it for you? Do I put it down? Oh, it's all a bit awkward. If it's the right arm that's missing, do I shake how do I shake hands and greet? And what about, oh, it gets messy. So it changes how people interact with the amputee. Other stuff can happen too. How I see myself if I've lost an arm or lost a leg profoundly changes. And it's not just appearance. Balance is affected. There's sensory feedback that's affected. Next time you wash your face, try this. Wash your face with two hands, but raise one index finger away so you don't wash your face with that index finger doesn't touch your face. And just feel how weird that is. Just something as simple as that can be very, very strange. So what I'm looking at is, are there factors in the person's life, and these will be largely psychosocial, that are causing them a problem? For example, sometimes the partner can't bear to look at them. Or they have to fix an eye contact. They can't look down. Sometimes people will be staring. Can you imagine everywhere you go, somebody asks what happened? And everywhere you go, you meet new people. What happened to you then? And they might even do this. They might go, here's a joke. Do you want someone lend you a hand? They make jokes. About standing up for yourself and things like that, because they're trying to deal with how they understand the thing to be, and they feel awkward. They're trying to diffuse tension. These can be problems. If you look around the bedside of somebody who's lost a limb, when it first happens, and the relatives and the visitors, you see different behaviors that people adopt. There's the joker, the person who's always looking on the bright side. You have the pity person. Isn't this awful? Family and relatives and parents can be devastated because that's their son, that's their daughter that this has happened to. You'll have the angry person, the person who thinks there should be punishment and people should be sued and all this, and there should be revenge. You get all these different responses. And often the casualty with the amputation has to now not only deal with the amputation and the pain and the change in body image and like, I was right-handed and now I don't have a right hand, what am I going to do? And they now have to deal with the change of behavior of everybody else. This can be quite a difficult thing for some people to adapt to. And some relationships will break down. Not because they can't cope with the amputation, but because people can't cope with the change of identity, because now how do I behave and talk with that individual? That can be a problem. I'm also going to be looking at the social adaptation that people have. What is the reaction of others? How do they deal with it? Do they have a sense of embarrassment? Do they have a sense of shame? How do they react to other people's pity, other people's humor? Some people are aggressive. Some people have this weird thing. If someone's different to us, we must be hostile towards that person. How do they deal with those kind of things? There's something that I've seen so many times, and I don't understand it. Not everyone that has an amputation is limited to just having an amputation. They might have other injuries. So they might end up, say, in a wheelchair. They might have facial disfigurement. They might have genital injuries. This is one of the things that it just never gets discussed or talked about on the TV shows or in the media. You know, the guy's lost both his legs in a blast. The chances are he's lost his genitals as well. These are hugely problematic and have huge impact on the individual. The social adaptation is, are they able now to fit in with other people, or do they have emotional reactions in turn to other people's emotional reactions? And do they now see themselves as a charity case? Do they see themselves, are they angry? Are they now the person who goes around with a degree of hostility? I was sat in a pub with somebody years ago who was an amputee, and she sat there, and I tell you, she was just glaring at everybody. She was just waiting for somebody to look so she could try and pick a fight. It was the most extraordinary experience. I was like, wow, this is uncomfortable. She had no awareness that she was the one that was actually instigating the trouble that she kept getting into in pubs. She drank to relax. Yeah, this didn't seem terribly relaxing to me. Yeah, the other thing is people in wheelchairs. I don't know why, I'm seeing this, I don't know how many times, why when a person is in a wheelchair does somebody always stick an L plate on the back of the wheelchair? I don't get it. They're trying to make light of it, but the person who is now in the wheelchair has no choice but to laugh along with it, otherwise they get angry and they elicit pity. And there's all these weird things that people do, and I've seen staff do this as well with people. Any questions about that bit, by the way? I'll take that as a no. Right, other stuff. Secondary depression and anxiety. Depression is most likely to arise where there's guilt and regret. Okay, that's where we're most likely to see it with an amputee. And somebody who's lost a limb is quite likely to have guilt and regret in some capacity. The guilt on the impact to others, the guilt on the impact on the relationships, the guilt for whatever the responsibility they may or may not have had inside the incident. They might be diabetic and overweight. They could have prevented that. How many things do you see on Facebook every single day about how these things are preventable? And that if only the government educated people in the pharmacy industry wasn't organized around making profits and actually educated people correctly, then these people wouldn't suffer and cancer wouldn't exist, because pharmacy creates customers. It doesn't create cures. And you see this idiotic mentality, I think it's idiotic, that people have. And so now we have a person who, so how did you lose your leg? Well, I've got diabetes. Oh yeah, I can see why. They may not say it, they may not write it, but the expression conveys it. And there's a degree of expectation that occurs as well. So this can lead into all sorts of difficulties. And you hear people say things like, I've only got myself to blame. Well, it doesn't help. Anxiety is going to be much more around future. What's going to happen to me? Will anyone find me attractive again? Will I be able to work again? Am I going to have to take on a certain role now? Has my identity changed? Before, I was a high status individual. I worked as a senior management role and all the rest of it. And now I'm relying on charity. For example, we get this massive status adjustment that can occur. And all this can lead to an awful lot of anxiety. At the base of that, what if questions? People will ask, what if this, what if that, what if things were different? Well, they're not, so good luck with that one. And I'll work with people around what ifs. Yeah, are there future consequences? Here's one of the things. A lot of people, their surgery's not over yet. They may have had an amputation, but they may have other things going on in the body. They may have other injuries, so there's further work to be done. They might have more than one limb that's injured. They've taken one off. we're going to try and save the other one. And that process might take months or years. It's not one of these things that happens in just a matter of days. They may work for a long, long time to try and save the limb first. Other issues that are worth treating: insomnia, particularly where there is pain and particularly where there's anxiety. And also, of course, guilt and insomnia are associated. And also things like sex drive and libido are these... When a person loses libido, they can often change their identity as well. That can then impact on relationships. Will their partner find them attractive? Is their partner actually only having sex with them as a charity case? These are some of the things that... you see the photographs of the war veterans where he's come back and he's horrifically disfigured. He might have lost his arms, he might have lost all the skin off his face, and now he looks like just horror. And the fiancée who he was going to marry before he went to Iraq, wherever it was, marries him. Brilliant. Except it's now put onto the internet and framed, and it's put into the magazines, and it's framed to be, isn't this amazing? Isn't she an amazing woman to still marry the freak? And that's the sub-message that's being conveyed with those things. And all of these images, all of these messages accumulate and take have a cost on the individual. So these are other considerations there. Am I a complete person? Am I still a man? Is another one. As I say, the other consideration is facial and genital injuries, which is just never discussed. I never see it openly discussed anywhere. I think I'm the only person I know of who works clinically who just comes straight out with that question where I think it's going to be an issue. People just don't talk about it. Right, other considerations. Pre-morbid conditions. Pre-morbid to the amputation or the injury that caused the amputation. Amputations and phantom limb pain occur to people who have lots of problems, as well as people who don't have any problems. And this can start to confuse the picture. So you might have somebody who, for example, is neurotic as they come. They have chronically low self-esteem, they're a people pleaser, and they drink a lot of alcohol. That's what they do. And then something happens, and for whatever reason, they lose a limb. That's going to exacerbate existing psychological morbidity in terms of the problems they've got. Because if they couldn't cope with life to begin with very well, this isn't going to help. For some people, and I hate to say this because I know how offensive it can sound, for some people it's the best thing that ever happened to them. Really is. Because now they can justify, you see, if I'm emotionally hurt, I'm psychologically messed up, life's really confusing, I'm confusing and I don't really understand it. How do I understand and explain this to me or to anybody else? How do I explain this? Oh, but because it's what happened. Now I have a peg in which to hang the explanation. Now that can be a confusing picture, clinically. So I will ask people about how they were prior to the accident or the illness or whatever it was that led up to the amputation. Because we need to differentiate between what is a pre-morbid condition and what is a consequence of the amputation. Otherwise it can get very, very confusing and we're trying to treat things with the incorrect or inappropriate methodology. My observation is that people with high self-esteem, high confidence and low neurosis tend to fare much, much better than people with low self-esteem, low confidence and high levels of neurosis. And I do wonder if in part this comes with family. Some people come from environments where the family is just neurotic. They don't have that thing that makes the person feel like they can deal with life. They've had to work it out themselves. Other people come from families where they are taught very well how to deal with life. That, of course, then impacts upon things like dysmorphic distress and social adaptation. So it gets quite a confusing picture. Right, other psychiatric stuff. Was the person depressed previously? Do they have a history of depression prior to the amputation? So that would be a primary depression in the context of what we're dealing with. Do they have a psychotic history? Did the injury occur during a suicide attempt? That's not entirely unknown, especially when people jump and land feet first. That's just horrendous. And they survive, but they can end up either completely crippled or they could lose limbs. And other stuff is psychosocial things. So probably, I would say, very important question to ask: does the person have a history of normal relationships with other people? Are they somebody who is promiscuous with multiple partners? They have very intense short-term relationships. They don't really have a relationship with anybody. They've been abused in relationships. They are the abuser in relationships. This gives you a good idea about psychosocial adaptation and how they will deal with the amputation they've got. What's the relationship with the family like? I guess about half the population, their relationship with the family sucks. It doesn't improve when there's an amputation, but it does now have a focal point for the interactions. And the focal point might be the elephant in the room that no one discusses. We all know it's there, but we skirt around the issue really, really carefully. So these are things, again, I will have a full and frank conversation with the individual around these things, because it's very important to be able to know this. What's the person's employment history? One of the problems that can occur is what can you do if you're a manual worker and you're very good with your hands, that's what you do, but now you've only got one of them and it's not your dominant hand. Now what you can do? It kind of changes the dynamic of what people are able to do for employment. What was their previous employment history? Some people are just rubbish when it comes to the world of work. They can't keep a steady job. They've never earned very much money. Their opportunities have always been limited. They've never successfully got additional qualifications and increased their job opportunities. Nothing has ever, they were never going to amount to being a high achiever. Now they have an amputation which further limits their opportunities and can now be an excuse and justification. And in terms of secondary gains, this can be something they would jump on. But I can't get a job, can I? And they may have been doing that before. I can't be expected to work in my condition, but they were doing that before the amputation. So again, important considerations. From a therapeutic point of view, secondary gains can always be found in any context of any problem. We can always frame something to say, well, he's depressed. Yeah, he's been depressed a long time, hasn't he? Doesn't have to go to work though, does he? Doesn't have to do the dishes. Secondary gains, so we can see why he's depressed. That is a therapeutic behavior that I find abominable, because we can always reframe something to have secondary gains. I'm not entirely sure it's of any benefit therapeutically, apart from its serves to accuse people of stuff. Secondary gains may be real for some people. For other people, they may be an imposition from a psychologist or a diagnosing clinician or a therapist. Either way, working with secondary gains therapeutically, I have never found to be effective, ever. It doesn't seem to have any use to me. What it does tend to do is damage the relationship between the clinician and the client. So I always say, specifically, never explore secondary gains with people, no matter how obvious they appear. Leave that to the psychosocial factors in the person's life. Their husband, their wife, their kids, their parents, or whoever else. I don't think it's a therapeutic issue. All of the things on that page, every single one of them, will affect pain perception. My experience has been that some people with intractable chronic phantom limb pain no longer have phantom limb pain when I deal with those issues, if they are present for the person. Simple as that. I will deal with those prior to bothering with the mirror box, if these things are clearly a problem. That said, the vast majority of people that I work with phantom limb pain don't have any of those problems. And that always surprises me. How it surprises me with people's adaptability to what is actually a major injury and a major change in the body. But where I have had clients who have been using the mirror box unsuccessfully, and I deal with whichever one of those is emerging, the pain goes away. Doesn't go away straight away, but it does go away. I feel like I've talked too much. That's really just the intro. I just wanted to give a background to stuff before I get on to the practicals. Any thoughts, queries, questions, problems, protestations? Absolutely no idea. No idea whatsoever. This is part of the problem, because what is the correct response set? I've always said, half jokingly but half seriousness, if I discover I've got a terminal disease, I'm not telling anybody. Because I've seen what happens, because you have to behave some way to the person, and what do you do? You know, and what do you do also when it's a person in your family who, let's face it, how many people have relatives they don't actually like, but they have this kind of relationship where they're able to, they get on, they've agreed, there's, you know, without any written rules or spoken rules, that there's lots of things they won't talk about and lots of places they won't go to in terms of conversation. But let's face it, they hate each other. And now one of them's horribly injured. That doesn't change, that doesn't go away, but now they might have much higher level of contact and a much more intense level of relationship as a result of this, in an already problematic relationship. And the amount of arguments I've seen on the hospital ward is extraordinary around people who've got quite significant life-changing problems, because the fractures in relationships become much bigger, it seems. So I have no idea. I just know I'd try and avoid the whole thing if I can, which in itself is probably a problem, and probably it could be a problematic response in some contexts to some people. How well did that go? I've been accused of the lacking sympathy for people suffering, and I think it works for me, and it seems to work when I'm working with other people. How it would work for close relatives for me, I don't know. I guess it does. It's a very individual thing.